If you remember, we introduced Rudolf Virchow as the father of pathology, and he is every pathologist's hero. He has so many wonderful contributions to the way we think about diseases, starting with the spectacular statement that all diseases are the result of abnormal histology. Well, he also has a major role in coagulation, and he developed a triangle which lasts till today. And even though I could probably rattle off 24 things that would contribute towards thrombosis, they can all be summarized in 3 categories, and that's why they call it Virchow's triangle of endothelial injury, abnormal flow, and hypercoagulation. If your endothelial cells are injured, disrupted, anatomically, physiologically, that is a main thrust for thrombosis. If the blood flow is non-laminar, perhaps it is static, sluggish, or has a lot of eddy currents, that's another contributor towards thrombosis inside of a blood vessel. And all of the things that we can think of which would accelerate coagulation from our diagrams of intrinsic and extrinsic pathways and controls and on them is another major contributor. That's Virchow's triangle. It has lasted until today. If you look at the endothelial injury side, you remember we said that endothelium is the nicest guy in the world until you mess with it. Then it becomes from Dr. Jekyll into Mr. Hyde. And all of these spectacular antiplatelet, anticoagulant, fibrinolytic properties then turn into prothrombotic, some of which completely do the opposite of what it does when it's not messed with. So that's the endothelial part of the triangle. In the abnormal flow part of the triangle, if you think of laminar flow, you know, the little physicists draw vectors and they have little arrows showing how smooth they are, laminar with well, if that's disrupted by perhaps other clots or venous or arterial abnormalities or perhaps problems with cardiac motion like atrial fibrillation, that induces turbulence or eddies. The arrows are no longer straight, they are now little circles. Or if there's stasis of blood flow, perhaps due to venous problems in the veins, these are all contributory abnormal blood flow. And don't forget, disrupted endothelium in itself introduces abnormal blood flow. And once that endothelium is disrupted, we now have platelets in direct contact with ECF, and you know the platelet plug is going to start there, isn't it? If you look at some of the inherited hypercoagulability factors, the single most common is a genetic deficiency of factor V. If you have a board question, I promise not to talk about the boards because I have contempt for them. But if they introduce a patient and it looks like they have a genetic or inherited coagulation problem, most likely it's going to be either factor V or prothrombin, because those are the most common. It's also fairly common to have mutations in the prothrombin gene or mutations in the methyl tetrahydrofolate gene, if you want to remember those. The other ones are all rare. I mean, there's such a thing as an antithrombin 3 deficiency, protein C, protein S, and fibrinolysis defects, but these are all very, very rare. And I guarantee you'll never see one in your lifetime. But you should probably know about them anyway. I warned you I'd be bringing this back, and I just wanted to remind you again about the triggering of coagulation from both the intrinsic side as well as the extrinsic side of the equation, going from 12 to 11 to 9 to 10 on the intrinsic side, and on the extrinsic side, tissue factor triggering off 7 to become 7A, and that directs acts directly then on 10 to become 10A. And you know what happens after that? Prothrombin to thrombin, fibrinogen to fibrin. That's the whole scheme. And I think sometimes when we have important concepts like this, even though I spent like 8 minutes on it last time, if I think it's really, really important, I'll introduce it again. Let's talk about some acquired hypercoagulability situations. And some of these are logical, I hope. If not, you know that if you have prolonged bed rest, you have prolonged venous pumping, impaired venous pumping, don't you? And therefore, you're likely to have coagulation, especially in the deep veins of the lower legs, patients that are immobilized in bed for a long period of time. Myocardial infarction can introduce problems in flow, especially in the flow in the chambers of the heart, especially atrial fibrillation, in which the atria don't really beat, they just kind of quiver. That certainly is abnormal flow from the that end of the triangle. Tissue damage can trigger off tissue factor, whether it's from extensive surgery, fractures, or burns. People with cancers, especially GI or pancreatic cancers, can produce compounds which will produce a direct thrombotic effect on veins. That's called Trousseau's syndrome. Prostatic cardiac valves can disrupt flow and trigger off coagulation. DIC itself is a process we'll talk about later, but in it you have coagulation going on in all of the small vessels of the body, and that's a tremendous consumer of platelets and the consumable coagulation factors like factor VIII, so you could have hypercoagulability in DIC as both a result and a cause. Thrombocytopenia can result in hypercoagulability. Patients on heparin are always at risk for thrombocytopenia, as well as this other long list we talked about before. And there's an antiphospholipid antibody syndrome. Lupus anticoagulant syndrome is a really good example. Patients with lupus make a little protein which results in blood from coagulating properly. It's called lupus anticoagulant. If you want to remember that cardiomyopathies, nephrotic syndrome, hyperestrogens like pregnancy, oral contraceptives, sickle cell anemia, smoking, obesity, these are also risks for hypercoagulability, but not as big as the ones we mentioned before. Let's talk about the morphology of blood clots. If they adhere to a cardiac chamber, it's a mural thrombus. It could be either atrial or ventricular. If they adhere to an artery or vein, they could occlude it, or they could partially occlude it. So the clot can therefore be obstructive versus non-obstructive. And like in the aging of pathologic processes, clots are at first red. After a few days to perhaps weeks, they become yellow by virtue of the fact that macrophages come in and start chewing up fatty substances. And of course, with time, they become grayish and white from the fibrous tissue, just like in the sequence of events we talked about in acute inflammation that happens with clots as well. A very acute clot, hours to days. We talked about organizing blood clots. These are the ones that would be yellowish or grayish. They're in the range of, let's say, days to a couple of weeks or so. And then old clots are weeks to months. And old implies fibroblasts and collagen. Organization implies a lot of ingrowth of blood vessels. And acute blood clot involves mostly fibrin and red cells morphologically. Here's a mural thrombus adhering to a ventricle. Here's a mural thrombus adhering to the wall of the aorta. If a systemic arterial blood clot occurs downstream, it's about 3 or 4 times more likely to come from the heart than it is the aorta. But those are the only 2 possible places anatomically, aren't they? So let's keep that in mind, and we'll start off the next chapter with slide number 71. Thank you very much.